it's not about a restrictive approach versus a liberal approach or moderate approach. It's all about limiting the cumulative fluid balance because we all know this is associated with increased mortality without compromising the perfusion of the organs. And to do that, we can devise a plan, an integrated approach to limit the overall cumulative fluid balance. For example, in the rescue phase, when the patient is in a dire state and collapsing very rapidly, here we go for rapid fluid boluses. And there is nothing wrong in it. But instead of giving a 30 ml per kg body weight fluid as recommended by some guidelines, it is better to follow the original description of Sir Thomas Leta and give a small volume of fluid and see how much is the effect on our patient. And how much should be the small volume? Probably a 4 ml per kg is a reasonable approach as suggested by Dr. Aya and team. Another approach is if the patient is uh, having a diastolic blood pressure of less than 50 or a diastolic shock index of more than 2.3, suggesting a highly vasodilatory state, starting a vasopressor, especially norepinephrine, along with fluid therapy or fluid bolus is going to reduce the cumulative fluid balance further. Elsewhere, we should use a vasopressor maybe after 1 to 2 liters of fluid. So early vasopressor initiation can limit our cumulative fluid balance. In the optimization phase, where the patient is not in dire emergency, but we may or may not require fluid in such phases, where the patient is still hypoperfused, one way of giving fluid and probably is to look for a fluid responsiveness before further fluid boluses. If the patient is not fluid responsive, we should not give even a single drop of fluid. But if the patient is fluid responsive, we should always look for uh, whether the further fluid is going to harm our patient or not. In this stage, probably a hyper-oncotic fluid bolus, hyper-oncotic albumin bolus is going to help our patient in reducing the overall cumulative fluid balance. But we need to have more data regarding the later approach. In the stabilization phase, where the patient is adequately resuscitated, probably the way to limit cumulative fluid balance is to restrict our maintenance fluid or something called fluid creep. Majority of our patients in intensive care unit, they do not require maintenance fluid at all, but we continue to give them maintenance fluid, as has been seen by certain studies that, in fact, 1/3 of the cumulative fluid balance in an typical intensive care unit patient is because of the maintenance fluid. This can be curtailed by initiating early enteral feeding. Furthermore, we can also reduce cumulative fluid balance by reducing something called fluid creep. Fluid creep is nothing but the diluent we use for delivering different drugs in intensive care unit. Now, this diluent can be reduced significantly if we actively look for it. If at all we read maintenance fluid, studies have shown that moderately hypotonic fluid should be used in adult patient to reduce total cumulative fluid balance or total sodium load in the patients. So moderately hypotonic fluid compared to an isotonic fluid as a maintenance fluid is preferred. In the evacuation phase, when the patient is now getting better, but unfortunately, because of the cumulative fluid balance itself, he or she is not responding completely. So this condition should be recognized early. This condition, which is also known as the global increased permeability syndrome, a recognition of this syndrome and a timely and judicial implementation of a de-resuscitation strategy can help us in reducing the cumulative fluid balance. So following an integrated approach can limit our cumulative fluid balance without compromising perfusion of the organs.